Good afternoon, everyone. My name is Rhonda Smith. I'm the Executive Director of the California Black Health Network, and welcome to this year's first Health Equity Forum, navigating HR1, as some people call it, the One Big Beautiful Bill. Not so much, but what's changing, what's next, and how to stay covered, featuring Dr. Monica Soni, the Chief Medical Officer at Cover California. So today's Health Equity Forum is really meant to uplift and recognize significant milestones in healthcare, especially here in California. And for one, as we wrap up Women's History Month, I really wanted to take a moment to recognize, celebrate, and honor an amazing human being that I've had the opportunity to get to know in my role here at CBHN, who is an amazing woman, an amazing leader, and a trailblazer. Our guest speaker today, Dr. Monica Soni. She made history in May of 2023 when she became the first Black person and first African-American woman who was appointed to the position of Chief Medical Officer at Cover California. I also want to take a moment to celebrate something for CBHN and a milestone for us. In 2025, we celebrated our 10th anniversary as a Cover California navigator. And over the 10 plus years, or 10 plus past years, we have enrolled nearly 5,000 people into Covered California healthcare plans or Medi-Cal. So thanks to the hard work of our partners and our certified enrollment counselors, we were able to achieve that critical mass of enrollees. And so this year, the ACA, or for us, Covered California, turned 16. And as of 2026 or early 2026, nearly 2 million Californians have secured health insurance coverage through Cover California. Now, since its inception in 2014, Cover California has provided healthcare coverage for over 6 million California residents. That's something definitely to celebrate. However, HR1 is not necessarily the best Sweet 16 birthday present that Cover California was hoping for, but it is important to shed some light on what this sweeping piece of legislation really means for all of us. So today's Health Equity Forum is focused on the impact of HR1 and the resulting policy changes and budget cuts and what that looks like it means for Californians. But before we start the program, I'd like to cover just a few housekeeping items. So we'll hear from Dr. Soni. She'll talk about what's happening at Cover California, what they're doing, how it's impacting, how HR1 is impacting Californians and Cover California access. That'll be followed by a Q&A. So if you have any questions, hopefully you came armed with lots of questions. Please place your questions in the Q&A box at any time during the session. If you want to give a shout out to folks in the chat box or make some comments or share your thoughts as we move through the program today, please do so, but remember to put your questions in the Q&A box. And so everyone except for the speakers will remain off camera and silent throughout the duration of the webinar today. So before I introduce Dr. Soni, for those of you who may not be completely familiar with the California Black Health Network, I'd like to take a few minutes just to give you a quick overview. And so we are a 40-plus-year-old organization, 40-plus-year-old statewide Black-led organization that works to advance health equity for all Californians. And so we are known as the voice and trusted resource for Black health equity here in California. And again, we are the only Black-led statewide organization dedicated to advancing health equity for all African Americans and Black immigrants. We conduct outreach, education, and advocacy and policy work, as well as programmatic work to achieve health equity for Black Californians. And we do that through the lens of understanding the critical issues that lie at the intersection of racial justice, social justice, and environmental justice. And in terms of kind of what we envision or aspire to do is we hope that we can create a California where all Black residents can live long, healthy lives that are free of systemic inequities, and communities are empowered to really define and drive their own health outcomes and future. And I think that is a critically important thing to be able to do, especially now with this new healthcare landscape that we're all trying to navigate through and figure out. And so we work to achieve that vision or realize that vision every day through our mission, and that is to advance health equity for Black Californians by improving health literacy and health empowerment and strengthening community power as well as advocating for protecting the health and healthcare of our community. So I'm really excited to hear Dr. Soni today. She is, as I mentioned, is with Covered California, and just wanted to take a minute to tell you a little bit more about her. So Dr. Soni is the Chief Medical Officer at Covered California and a Chief Deputy Executive Director. She is a health equity leader and a champion. She brings a unique perspective and her passion to her work in advancing health equity for the most vulnerable communities across California. And in her role at Covered California, she leads the organization's Health Equity and Quality Transformation Division, and where she works to improve the health of Covered California enrollees and the quality and affordability of care for all Californians. In this capacity, she's responsible for health equity, healthcare strategy, medical policy, and other clinical operations to continuously improve not only the health services provided through Covered California's contracted health plans, but also California's delivery system. She is a board-certified internal medicine physician with more than a decade of experience working in both inpatient and outpatient settings, and continues to see patients. Considering the job that she has, I told you how amazing she is. I don't know how she does it all, but in her current role, she still sees patients, and I think that it's important to stay connected to the community. She's also an associate professor at UCLA Department of Medicine and the Charles R. Drew University Department of Internal Medicine, where she is committed to residency, diversification, and pipeline development. A graduate of Harvard College, and there she graduated cum laude with a bachelor's degree in anthropology. She received her medical degree from Harvard Medical School and completed her residency in internal medicine at the University of California, San Francisco, with a focus on primary care. In addition, Dr. Soni was a fellow in the California Healthcare Foundation's leadership program and the Carol Imott Foundation Fellowship. She is currently a board member for Mercy Housing California, a leading affordable housing organization, and previously served as a commissioner for the Los Angeles County Hospital and Healthcare Delivery Commission. And on top of all of that, she is a devoted mom and family member, and I told you she's amazing, so kudos to her for doing it all. So thank you, Dr. Soni, for being here. I'm going to turn it over to you to take it from here.
Thank you. Well, I truly feel loved with that introduction, and I really appreciate the strength of the relationship that we have, Rhonda. And thank you all for spending, for many of you, your lunch hour together here. I'm going to pull my slides up, and the slides will come out as a resource, but I want to particularly ground you in the fact that I put a lot of information in there for you so that you have it, but also want to make sure that we have plenty of time for conversation. So I'm going to move at a relatively swift pace to make sure that we can hold some time there for conversation. All right, so Rhonda did a great job of laying this out, but I want to ground us first in the Affordable Care Act and kind of where Covered California was born. I am going to talk specifically about Covered California because I think it frames where the federal changes really have been very swift, and the timeline and the impacts, and it parallels what we're seeing in Medicaid and other programs as well. So I'm not the Medicaid expert or the Medi-Cal expert, but again, you'll see that I'll nod to where we see the same ramifications and implications in that program as well. First, I think we should celebrate. I know it's been tough. Every day is a little bit tough, but if we can start by celebrating what we have accomplished in California, we went from nearly over 17% uninsured to under 6% uninsured. That is incredible progress, and actually it disproportionately benefited communities of color, Black folks, and folks identify as Latino across the state of California. The marketplace was always created as this bridge. So if you don't have coverage from your employer, you're not old enough yet for Medicare, and you don't meet the income requirements for Medicaid, where are you to go? And that's really what the exchange was created for. I want to talk a little bit about who do we serve? So it's hardworking Californians from the top of the state to the bottom. 1 in 6 Californians has been on Covered California since the inception. And, these are small business owners, contractors, gig workers, folks that are really working hard for every single dollar and are making tough trade-offs between what should that dollar go to. You heard about the numbers already from Rhonda. This year, after open enrollment, we're just at that nearly 1.9 million enrollees. We'll talk about how this open enrollment was a hard one and where we lost a lot of folks who were covered. About 3% of the folks that we support self-identify as Black. And then in that tiny box there, I want to just draw your attention to this really critical number, which is, 4 out of 10 enrollees are less than the 200% of the federal poverty level. That's low in California. Like, to live off of some of the incomes that we see here is tough. So these are folks that absolutely day in and day out are making decisions about, do I pay for insurance or do I pay my rent? 47%, we survey our members every year, and 47% of our new enrollees told us that they felt like they did not have enough money to make ends meet in the last 12 months. Also, high rates of food insecurity, medical debt, and even instability in housing, right? We have a number of folks that have experienced homelessness. So sometimes when we think about what's covered California, what is the marketplace, there's sort of a different picture in our mind because it's quote unquote commercial insurance, but these are folks that flip on and off Medi-Cal, other forms of coverage, and again, are making these difficult financial trade-offs every day. So that's a little bit about Cover California. You'll have all this material, and I put some great resources and links at the very end of the deck too that goes a little bit deeper in terms of other programs. But I'm going to focus on the federal impacts and the federal changes that have happened for us. And while the webinar was called HR1, one of the things I'd like to make sure that folks on the call take away is that there's a number of different ways that the federal administration has made changes, some in the form of HR1, but there's a lot of other tools that have been used too. And some of it's just direct rulemaking from CMS straight to marketplaces or CMS straight to Medicaid programs. And then some of it is just funding cuts, even separate from HR1 as well. These 3 buckets are the buckets I'd like you to think about. It's the way Covered California is being impacted, but very much parallels what's happening in the Medicaid side as well. So finding ways to decrease enrollment, new administrative requirements, red tape, things that decrease eligibility or make it hard to get enrolled, just making it challenging. Enormous restrictions around which immigrant groups are eligible. I'm going to talk about this in some more detail, but really a substantial change around lawfully present immigrants. And then, just the funds, affordability, the number of dollars coming from the federal government back into the state substantially decreased. But also, separate from HR1, same categories, same changes coming directly from CMS to the marketplaces, both the federal marketplace and then state-based marketplaces like us on Covered California. And it's things like, we used to have an open enrollment historically that was able to run from November all the way through the end of January. We knew that a lot of our sort of younger people like to kind of skirt in right at the very last moment. So we had huge increases in enrollment that last week of January. We don't have that time anymore. Starting this next open enrollment, it will be shortened to just 9 weeks. So we got to get everything that we got done for those nearly 2 million people done now in a much shorter period. So it's examples like that, right? Like things that just make it harder to get the total volume that we want to support in care. Other things like restrictions and changes around income requirements as well, and then more friction. So having to sort of pay more, verify more, pay upfront, things that we didn't necessarily have to do in the past. You see the little justice icon there. We'll talk more about this, but we have a very active attorney general, and others across the states have filed lawsuits about a number of these areas. And so where you see those little icons is where there's a stay, meaning we don't have to implement those changes yet because it's being discussed still in the court system. Here's another, we every year also get what's called a notice of benefit and payment parameters. It's another tool that CMS can use to change how we're able to operate. And it comes every year. So we're talking about HR1 sort of in this kind of past tense, but every year we get new rules and regulations that come to us in our Medicaid program as well. So let me say a word about sort of those same categories just in the Medicaid space, because I know you all are thinking about that, right? 1 in 3 Californians is on Medicaid. 50% of the births, all of the babies that are born in California are born on Medicaid. The vast majority of kids in California are on Medi-Cal, and so really substantial implications there. So in that space, parallel things have been happening. We see just freezes of federal funds in the health space, in the housing space, in the social services space. Same thing, kind of new and different interpretations of legal language. Similar changes around uh, sort of interpretation of who from the lawfully present immigrant group should be eligible for benefits. This one is really a heartbreaking one for us. These are folks who are asylees, refugees, folks that have suffered from trafficking, who are no longer eligible through our program or even on the Medicaid side for some of those federal funds. Again, in kind of that eligibility red tape category, that's where, and I know you all are thinking about work requirements, that's sort of a parallel on the Medicaid side, or 6-month re-verifications for some Medicaid enrollees in that kind of eligibility friction side. There's also substantial changes to state financing. So you may have heard things like the MCO tax or managed care organization tax. There's restrictions now about how much flexibility states have in terms of using financing structures like that, that we'll talk about towards the end of the deck. And then same thing on that, the Medi-Cal side, who counts as a lawfully present immigrant and is able to receive sort of federal programming and federal funds. Some big numbers across the Medi-Cal program in terms of folks impacted. For us, we were estimating about 400,000 covered California enrollees might leave over the course of 2026. For 2027, we have about 120 of those impacted lawfully present immigrants currently on covered California who will lose all federal support. It's bigger numbers, of course, on the Medicaid side. So, some of the numbers are that maybe 1.3 to 1.4 million current Medicaid enrollees or Medi-Cal enrollees might not be able to successfully get through the work requirements and would go uninsured. Similarly, in that kind of impacted lawfully present immigrant group, about 200,000 Californians would not be able to have coverage on the Medicaid side. So again, we have sort of this overlap across the programs of similar categories of federal changes impacting us at the same time, 2026, 2027 being a huge year. So this is the number I shared with you that we're using as our estimates. In terms of that category of funding changes, we lost $2.5 billion in federal funds at the end of 2025. Those funds went directly to enrollees. It was what folks used to be able to afford their plans for their premiums. And so that expired. That was tax law that expired and was not extended. You may remember the federal government was shut down the first time over that, the longest shutdown in federal history over this issue. It's not back. And so I'll talk about open enrollment, but we're worried that kind of month over month, we'll see more folks not be able to afford their bills and sort of just over the course of the year, lose more and more people to being uninsured, kind of reversing that first graph that showed our incredible strides. We did much better than other states and frankly than the federal marketplace because we do have a state that is committed to healthcare and understands the importance of health coverage in terms of wellness, morbidity, mortality as being foundational. And so we were allocated $190 million to actually wrap around our lowest income enrollees to keep them on the exchange. And so there were folks that actually didn't see any change in how much they had to pay every month. Some folks that are able to still pay $50 a month and get very robust benefits out of that. So incredibly grateful to our governor and to the legislature for that appropriation. The math doesn't math. It didn't fill $2.5 billion loss, but so far we have 390,000 folks that are benefiting from that program, and so incredibly lucky to be in a state that that is committed in this way to maintaining coverage. Other states did not fare as well. So here's what it looked like. So, top line, not bad, right? More than 1.92 million Californians actually selected a Covered California plan through this open enrollment. So these are my hot off the press 2026 numbers for you. It was a 3% decrease compared to last year, but last year we eliminated deductibles for over 1 million people. So this totally different level of affordability. You see that the new signups decreased by over 30%. That's pretty substantial. But our renewals looked okay. Like folks that had already gotten a Covered California plan were kind of committed to continuing with that coverage, were able to figure out how to afford it if they did see some changes in their premiums. But this is where I want to draw your attention to who got hit the worst: middle income folks. And I use that term maps to 400% of the federal poverty level, which is still very low in the state of California, right? They have no support anymore. So what was at stake? Those federal enhanced premium tax credits that expired in December, that was the first support this group had ever had under the Affordable Care Act, and now they have nothing. So it's what we call the cliff. And they are the ones that saw huge increases in how much of their salary they would have to go towards paying for health insurance. And so we saw really substantial declines in that group. We also saw that folks were really shifting from silver. If you remember how it works on the exchange, we have metal tiers: bronze, silver, gold, and platinum. Silver is where we really like to see folks, because you have kind of good levels of coverage. You have a little reduction in how much you have to pay out of pocket when you go to see primary care, and your deductible is a little bit more mitigated. Bronze is different, right? It's a higher deductible, and so there's a lot of studies that suggest when you have high deductible type plans, you delay care, you don't fill your medications, you wait until you're so sick that you crash into care. So that's not the preferred place where we want people. And we did see a shift for new enrollees there. Among Black enrollees in California, a 34% decrease in new enrollment. So this was really, we saw decreases across, kind of every group, but among Black folks, it was a 34% decrease. So very, very substantial here. Now, I said we did a little better with the renewals, right? People had been on in 2025 sort of stuck around and stayed for 2026. But you can see a third of them switched from silver to bronze. Oof, that's tough. Those are folks who in 2025 may have been in the middle of chemotherapy or, about to get a surgery done and had to downgrade to a plan that actually they're going to have to pay more, out of pocket. So tough. This is a really tough shift, and we're going to see how this plays out across California throughout this year. And then cancellations here, you see among Black folks, the cancellation rate increased from, was 13% last year to 16%. And critically, this is sort of an interesting point. It was initiated by a user. So it means I got my notice to say, hey, it's time to re-enroll. I go in there, I look at it, and I'm like, no. That is a concerning trend for us. It makes us think that folks were deliberating and saw the cost point and potentially canceled because of affordability specifically. So that's definitely worrisome for us. And then again, back to that middle income family, we saw double the rate of cancellation in those folks, in those families, because they have no support. They have no tax credits at all from the federal government. So, in short, I don't know, we did okay. We did maybe better than we thought we might. And we've been watching these trends super closely. The takeaways are that we saw some equity concerns in terms of decreases in new enrollment. We saw more cancellations initiated by people. We saw really substantial impacts to middle income families. And then we saw shifts to bronze from silver. And so a lot is going to play out over the course of this year. And people will still, every month they'll get their bill and they'll have to say, can I afford this or not? And then they might cancel. Every month we'll probably see more cancellations over the course of the year. Okay, we're doing good. So get your questions ready because I'll have about maybe 10 more minutes and then I want to open up to you all. So impact to providers. So there's a great link, and this is, you can, when you get the deck, you can click on this. California Healthcare Foundation really summarized all of the different ways this is going to show up for our clinics and our hospitals and public health. And so one, think about everything I just talked about on the Medi-Cal side, on the covered California side. We're talking about millions of people now going uninsured, people who had insurance. We're not just talking about healthy people, people who had insurance, who were in the middle of getting things taken care of, now uninsured because of certainly affordability, but also like technical reasons, more friction in the system, more red tape. Those millions of people still have the same medical needs. If I was in the middle of chemotherapy and now I'm uninsured, that doesn't change. I'm still hopefully showing up to that clinic, to that specialist, to that primary care doctor, to that hospital. What are those people going to do? What is the delivery system going to do? That's what we call uncompensated care. It's care that they're going to have to figure out how to absorb to continue to take care of our sick and vulnerable population, but with no money. That is a very precarious situation that we're in. So one thing that's happening is more uncompensated care. The next part is actually reductions in direct funding. So, because of some of that flexibility that the state of California was using around, like I said, the MCO tax, but there's a bunch of other programs like that the federal government said, no, you got to phase that out. There are caps in how you do that. You've got some, kind of limitations in terms of how you can do that. There's going to be this decrease actually in reimbursement rates. So that's one across hospitals and across providers as well, because those flexible funds were really going to the delivery system. Rural, hospitals, we already know we have a number of distressed rural hospitals across the state that have required kind of emergency funds from the state. There's really not that deep pocket anymore. You may have heard about the Rural Health Transformation Fund, which the federal government put forward, and California was awarded funds, which is fantastic. But it's not enough to backfill how the level of cuts that the rural health system will see. And there's specific language in there from the federal government that says it can't go to distressed hospitals. It has to go to transformation efforts. It's not meant to be a backstop or to backfill. And then again, just specific challenges, reductions in direct funding from the federal match that was coming in from the federal government to California. So multiple hits. Okay, so not all hope is lost. It's tough though. I mean, it is heartbreaking. I see the comments. But I want to just be in gratitude with the folks at the state. As an example, California has been very active in health-related litigation. Our Attorney General, Rob Bonta, is, lead or co-lead in a number of different cases, blocking, like I said, some of those specific roles for the marketplace. You may remember that the CDC was sort of making changes even to the children's vaccine schedule. There was a lawsuit there, actually, that we got some success just recently. Data transfer of protected information. There was a preliminary injunction around that was there. And then, a number of specific provisions that were saying, well, we're not going to give you money for, birth control or, things like that. And also there was some litigation around that as well. Funds, I told you we were given $190 million, in advance of open enrollment to wrap around, which is incredibly helpful. And then there's a really important bill, AB 144, if you didn't see it come through, like folks move so fast. That bill was there to, help protect things like gender affirming care, help protect vaccine access, help protect preventive care access when we started to see erosion of those things at the federal government level. So really protecting public health for all. Like we just saw our legislature move so quickly on that. And now these are things that are being operationalized already. We talked about the Rural Health Transformation Program. It's $220 million, which is fantastic. And so, that work is underway. If you haven't been following that, there will be some public meetings where you can, see how our great sister division, HCI, is going to think about how do we sustain the rural health needs across the state, of which we have substantial, right, regions and populations in rural areas. Here's where I said there's some resources, just some great links. Bullet number 2, I would specifically draw your attention to. There was a webinar a couple months ago from Cal HHS that really walked through the Medi-Cal specific provisions, details about how work requirements will be handled, how to make sure that everybody across the community knows how to support someone so that we don't get stuck on red tape, but can kind of help folks get through the system as seamlessly as possible. So please take a look at that and stay scrubbed in there as well. So I think I'm gonna pause because I see there's a couple, Q&A. And yeah, Rhonda would love if there's anything else you want me to go a little bit deeper on.
Thank you, Dr. Soni. Yeah, it's like, well, I'm feeling some kind of way about, all of this, and I'm sure everybody else is. And we do have a few questions in the Q&A box, so thank you all for posting questions. So, first question we have is, do we have the percentage of overall covered California enrollees by health plan? I think that data is available, but yeah, I know. I appreciate you being a data geek. And I certainly, from a navigator perspective, appreciate that so that we don't have to do some of that number crunching ourselves. So thank you for that. So I'm sure you have the answer to that question.
We do. And one of the things I love about Cover California is we are very, we try to be very transparent. And so I'm putting in chat right now a public dashboard that showed how we did for open enrollment, and it does have enrollment by plan. And then we also have this other report that's called the active member profile that we do post. I think that we post it quarterly throughout the course of 2020. So every year we post it so you can see exactly where the membership is, and regionally, by race, ethnicity, income, all of that. So the dashboard that I put will show you mostly how open enrollment landed, but I can put the other link of where we put the active member profile as well.
Okay. And then someone wants to know if there is an expiration of CalAIM and how this will further impact the underserved community. And the example that they're giving here is recuperative care and substance treatment.
Yeah, so this one and I think the question right after that are really about what's called an 1115 waiver. So this is where, any state Medicaid agency can sort of put a petition out to CMS to say, hey, we want to use the money in more flexible ways, not just to pay for, doctor sees patient, pay for that thing, but all this other stuff that you all know that we know makes such a difference. I was in a session where a couple other states asked, CMS, how will they be thinking about 1115 waivers and extensions or, new submissions? And the message was pretty clear that they were not interested in funding most social needs and thinking about things like, some of the rent subsidy programs. And so, I don't want to speak for the Medicaid folks. I think that here in the state, I know that they are diligent and see the benefit of these programs. And so I can't answer those two questions. I don't know. But I do know that we are not getting a favorable signal from the federal administration on their desire to continue programs such as the largest ones in the nation, which are the ones we've implemented.
And then the next question, I think, to your point was, is the ECM program going to continue?
Yeah, I don't want to speak for my counterparts at the Department of Healthcare Services, so I don't have the details of that, but we have the waiver for the duration of the waiver. I'm not sure what will happen at the end of the waiver.
Great. And then, so what are some of the things that we can do to support our clients through this? It feels like there aren't a lot of other financial resources in the sphere of healthcare, but maybe it's supporting, connecting with other kinds of community resources to support other areas of life or what people need to get their basic needs met.
Yeah, my best shining light that I'll give an example of is I know you all remember when the longest federal shutdown happened, and folks' SNAP benefits or their CalFresh was also very unstable. Folks were either not getting it or getting reduced funds. And it was incredible, the groundswell that I saw in terms of linking to food banks, other resources, local, county-based, even statewide resources. Like I just saw the mobilization happen so quickly because we do actually have a lot of resources that just usually are not that integrated or that we don't point towards in a coordinated fashion. So we are going to need more of that. We are going to need to figure out where does that sliding scale program exist, in community. What is that? I hesitate to even say it because it breaks my heart to say it, but yes, where is that free clinic, or free, once a month dental service that we have? Yes, we are going to have to stitch some of that together and create a more comprehensive set of resources to help support folks. And so I know that everybody is resource constrained in this moment, and yet I think we do have kind of a patchwork that one needs to be a little bit more comprehensive about.
So, what are some of the best practices that you are seeing with counties and communities across the state to support the enrollment and re-enrollment process?
Yes, yes. So much. I mean, I think one of the things is that we at Cover California are extremely reliant, and I hope work in deep partnership with our navigators on the ground, our enroller partners on the ground, other community-based organizations, frankly, the clinics, right, that serve these folks across the state of California. And so one is, please let us know, what you are hearing. Rhonda knows you really can reach me pretty easily if you need anything. We've got a great team that wants to hear what's going on and be responsive and nimble to that. Over the course of this open enrollment, when we would see things in the data, we would pivot our approach almost in real time based off of that. So if you tell us we're able to move quickly, sometimes folks don't believe that about state, but we can really move quickly if you give us the information. So that's one, please give us the information. Two is that I do think the more that we can think in a kind of a regional coordinated fashion, right? Not every health plan is a statewide health plan, right? Like there are plans that are just in LA County and hospitals that are just in LA County and clinics that have a regional footprint. We need to be convening those folks in a single room and talking about this together. I don't think we should be doing back channeling. I think we have to be honest, transparent, and talk together about the realities and the challenges, who has capacity, who doesn't, who's willing to open the doors and who is closing the doors so that we can actually be routing and supporting folks in a coordinated way. So that's one thing I would really love to see more of, is each county being a little bit more transparent about how they're going to meet the needs.
Great. And thank you, Tia, for your question. So she says, thank you very much. He currently serves as a commissioner for the hospital and healthcare delivery systems for Supervisor Mitchell in District 2. And she's happy to know that she stands on your shoulders. So her question is, what disparities in health outcomes are you most concerned about right now among Covered California enrollees, specifically in LA County?
I'm an Angelino. I'm very worried about LA. Already, LA County is a huge county. We have high density. We already at baseline have high needs. When we saw that there was still, about 5 to 6% uninsured rate, most of the uninsured were LA County and mostly Black and brown folks. So from a baseline where we're starting is that we have more uninsured folks and more needs. And you probably know this as well as I know this, but there's some real fiscal challenges happening in LA County right now. And so I am worried, frankly, about Covered California enrollees who chose to terminate in LA. On the Medi-Cal side, folks that may not be able to get through the system in LA, and how much capacity we would need to open up to take care of uninsured folks in LA. And are we able to do that? Are we moving in the direction of having those conversations to do it? So I still see patients in LA, as we talked about, in LA County. I'm worried. And then of course we've got all the other stuff layered on top, right? Between people feeling afraid to come out as well. So yeah.
Yeah. And do you have any insight? I think you touched upon this in your presentation, but do you have any insight into how providers are going to be impacted and how they're feeling about all of this?
Yes. Well, I think the institutions, I'll start first with the institutions on the delivery system side. We already are seeing some impacts, as an example, and this is a specific set of circumstances because you all know that the federal government, names Planned Parenthood, but Planned Parenthood Orange County closed all their primary care clinics already. I don't want to misstate the number, but there was several thousand folks that were then displaced and had to find a new primary care provider. Luckily, the community was able to rally around that and absorb them, but that's what we're starting to see, right? We're starting to see that some clinics are shutting down, some folks are changing how much Medi-Cal they want to take. Those are the realities. These are the things that people tell me offline. So those are sort of the institutional response. And this is why I do think that we need more transparent conversation. I think we should be calling for more transparent regional conversation. And then on the provider side, I mean, I just feel like most of our clinical workforce did not recover from COVID. Frankly, it is extremely traumatizing, and there was really no healing. And then I think it feels the same to people. It feels chaotic. It feels devastating. It feels like there is potentially preventable mortality that I think our provider community feels very disempowered right now and angry.
And rightly so, yes. And so I know that Cover California doesn't really track Medi-Cal enrollment so much anymore, but we'll ask the question, if you have a sense of like how many people who lost Medi-Cal enrollments that may have been enrolled through. I know, we have a few through our enrollment counselors that didn't renew or, for whatever reason. I know that we know that our Cover California enrollments are down 66% for new enrollments compared to the previous year, and I think about 22% for renewals.
Wow.
But that's just Cover California plans. There's not a lot of data that we have access to specifically for Medi-Cal. So I don't know if you have a sense of that.
Yeah, maybe I'll start with one foundational piece, which is good in California, which is Medi-Cal and Covered California share a back-end system. So if somebody goes to renew their Medi-Cal and they make a little bit too much money, rather than let them sort of try to figure it out on their own, that comes automatically to Covered California so that we can try to automatically enroll them in an equivalent low-cost plan so they can have no gap in coverage and are able to continue with their same primary care provider or treatment plan. So and that was, again, a bill that was passed that allowed us to have more seamless integration and enrollment. That structure allowed us, I think, I don't want to misstate the number, but over 200,000 folks have been successfully moved through some of that process when we had the unwind, if you remember the Medi-Cal unwind, or when the public health emergency ended. So we have a great process for that. Here's one thing I have to say, though, so you all are aware. If you're still in the Medi-Cal income level, and you didn't, make it through your work requirements, you cannot come on Covered California. That's how the law is structured. You can't come on any marketplace. The law is structured such that the income bands are still fixed, because technically you're still Medi-Cal eligible, but you didn't do your work requirements. And if you're Medi-Cal eligible, you cannot come on Covered California. It's this terrible intentional gap. And so I'm really worried about those folks still.
Yeah. So the next question is, how do you see new innovations like AI helping in solving some of these problems, or maybe even filling the gap? I mean, I don't want people to rely on AI to get medical advice, but I know that is happening, right?
Yeah. Well, first, hi, Dr. Glover. That's my friend. Well, yeah, I think let's be realistic. That's already happening. When you look at a number of the surveys, folks are putting in ChatGPT or Google AI or influencers on different social media platforms. So I don't have my head in the sand about that. I have no problem with that. If our health system was robust and taking care of everybody, we probably wouldn't have that behavior, but we don't. And so we do have this behavior. I think for me, one of the things that's probably worthwhile, and I'm thinking about, your campaign, Rhonda, about really what does health literacy look like in this day and age? I think we should teach people, how do you actually put the right prompts into AI to get the right information so that you don't think you have some rare disease that when really you just have a headache. I think there's something about that that's probably right and ripe. And how do you click the buttons where it says where the information was sourced from? If you're using a tool that's a large language model to say, that's pointing me to a random, Reddit thread versus this is Mayo Clinic. And so I think that there's work we could do there, and I would love to be part of that ideation with anyone.
Well, I think you just gave us a new idea for one of our next How Do I
Great.
webinars. Right?
Please, I would love that. I think there are
Yeah.
people who are really smart about that and thinking about that in thoughtful ways. And then I think, yes, I think the provider community, we need it, right? We can't continue to burn out, particularly primary care, or expect folks to see more in what is a challenging environment without some more efficiencies. Um, I think what we know, though, Al, frankly, is that some of our big, more sophisticated systems already have deployed things like ambient scribes or technology, and we're continuing to leave behind our smaller independent practices, or even some of our federally qualified health centers certainly are, some of our safety net county institutions. We don't have robust AI implementation there. So I do think that it's an opportunity, but like who's gonna pay for that? I think we all need to think about creative funding sources to fill that gap.
Great. And then you mentioned the need for more regional conversations and transparency, but what do you see as the biggest barrier to those conversations, and who do you see as the logical convener to do something? Yeah.
We talked about this at your Health Equity Summit, Rhonda, which is, when scary things happen, everybody does this, right? You like shut doors, you tighten the belt, and you don't reach outward. It's the wrong impulse, right? Should we all do things redundantly by ourselves, or should we be out in the open and talking through it? Logical convener, honestly, anybody. I think, I'm happy to pull a list of like who the invitees should be in any region, or ideate with people on that. But I love that might come from community, right? Which is like, we want to know what's going to happen in my backyard about this. How are we keeping the doors open on this critical, clinical service? I think let's hold folks accountable. It's our taxpayer dollars. Let's hold folks accountable and ask them to come and talk about how they're dealing with some of this. Cover California, we try to talk about all the time. So I think others should as well.
I think you're continuing to give us ideas for like what other things we could do in terms of webinars or convenings. One of you brought up our Health Equity Summit that we did back in October, and we talked a lot about a call to action, what we could do, and not just in the conversation at the Health Equity Summit. So would love to talk to you about maybe if we can partner together to hold these convenings. Because that was one of the things that did come up, is like, what do we do to have maybe smaller convenings instead of one big conference to really address some of these things and take some action and figure out what to do and what some of the solutions can be. So,
Love
yeah.
that.
We'll
Please count
have
me in.
yes, yeah. Thank you. I appreciate that. And so can you provide some clarity on some of the new rulings of Medi-Cal recipients needing to have to reapply every 6 months, so for redetermination, and the paperwork and all of that's involved, and if they are unable to reapply, get reauthorized in a timely manner because of all the barriers. The question just went away. I didn't finish it, but I think you saw it.
I saw
I'm not sure. It just disappeared. I didn't touch anything.
I think
So
I did
yeah.
it. Sorry, Rhonda.
Okay.
Well,
Yeah. Sorry.
I put a link to
Okay.
that great Cal HHS webinar in January, because again, I'm not the Medi-Cal expert. I don't want to misrepresent what's happening around work requirements and work exceptions. But the deck that I just put in actually is very detailed about those pieces. But I'll state the thing again, which is really challenging. If by income you are still in the Medi-Cal income range, regardless of what happened with your 6 month or your work requirements, you cannot come on Covered California. That's how the federal law is set up. We are unable to enroll Medi-Cal eligible folks, even if they can't get Medi-Cal because of the new restrictions. So this is an area where I do think we could use some more ideation and thinking, right? Like, what's the tracking system for that? What do we do about that? How do we not let folks just be in limbo? So yes, I have no, when my sister laughed at me because when I hyped up this webinar, I said, I don't have all the answers. And she was like, dang, Monica, you can be really honest. I said, yes, I don't have all the answers about it, but I can definitely say to you, let's think about that together. I'm worried about that.
Great. And so this person says, since a great deal of HR1 does not become effective until after the midterms, can you describe some of your outreach education that's happening to keep people aware of the changes that are coming down the pipe?
Yes, yes. So you're absolutely right. 2026, I mean, a number of things have already hit, but 2027 is this big year, particularly for lawfully present immigrants and work requirements and some other pieces of the state financing restrictions on the Medicaid side. I hope it's more of this, right? Like the deck that you'll have has a lot of that detail. The deck from Cal HHS has timelines there too. It's true that it's dense and a little bit, kind of in the weeds. And I think we have to try to talk about it more, disseminate it, and make it clear about the impacts that are going to happen to our friends, families, loved ones, neighbors. Again, especially given how many folks across the state of California are dependent on both Medi-Cal and Covered California. So if you have more ideas about how to keep the salience of the conversation, especially given there's so much, right? We fatigue. I'm happy to come to other spaces or brainstorm with folks.
Okay, great. So I'm not seeing any questions right now, but I do have some that I want to ask you. And so let's say where to start. So, with everything that you've talked about, I'm not that I want to hear more gloom and doom, but let's say things don't change. Can you paint a picture for us for what you envision might happen if you want to pick in 2028, like
What is
theoretically?
California be like?
Mhm. Yeah, right.
So, I practiced before the Affordable Care Act passed. And I was still practicing hospital medicine as well as primary care. And frankly, I was doing urgent care too. And every week, somebody would come in with advanced metastatic disease in their 40s, cervical cancer, often breast cancer, colon cancer, that I was now having very difficult conversations with in terms of their prognosis because they didn't get the screening earlier or didn't come and they delayed care because they were worried, and a lot of that were Medi-Cal recipients, right? It's not just folks, the Covered California folks on commercial. I am worried that it will be worse than that. Why do I say it like that? I'm not trying to be hyperbolic. It's that in those days, we had all these workarounds, right? In LA, people remember we had My Health LA. We had all these regional programs where we knew how to get someone from primary care to specialty care to that medication. You know, those things were gone because we expanded coverage. We were expecting that most everyone would have insurance. We sunset those programs. We don't have as many even free clinics anymore. And all of these folks were accessing care. They were coming in to see their primary care. And now, like, we have these holes in the safety net. So I'm worried that it will feel like that again, where we all know that sicker people are going to be coming in mostly through the emergency room, and that the emergency room will have no place to send people. And the emergency room cannot continue to absorb that. And so we'll be doing a lot of, here's this piece of paper, go over there, maybe they'll see you. Because that's how it used to be. People would show up like this to me. There's one more story about this. People would show up like this to me and they'd be like, oh, I had a surgery. And they said, follow up here. I'm like, what do you mean? Where was the surgery? And then they would have 25 staples down their back from spine surgery, staples that had been in 3 weeks too long. That's how it was. That's the picture in my mind.
Yeah, so I know we're talking specifically about how HR1 impacts healthcare, but as I was listening to you talk, I was thinking about provider burnout and, overstressing the system and people maybe even opting out. But even with that, when we think about the pipeline, and I know that's something that you care about, there's a component of HR1 that impacts education and people's ability to afford to go to college or medical school. Can you touch on that a little bit?
Yes, there's been a couple interesting pieces that were about loan forgiveness,
Hmm.
actually capping loan forgiveness for docs and other clinicians. And then on the other side, limiting what professional types are even eligible. Exactly. And so that is very, I was the recipient of a couple loan forgiveness programs early on in my career. It didn't wipe away all my debt, but it wiped away my debt by like $100,000, enough that I was felt happy to go into primary care. I love primary care. I love primary care still. But had I been looking at that full bill, had I been looking at the $300,000, $400,000, I'm not so sure that that decision would have been quite as easy. And so I do really worry about pulling away these programs that you have people reliant on right now, people who are in the like eighth year of their federal loan repayment, just trying to make it to 10 years and now feeling uncertain about if they'll even benefit from all that forgiveness. It is very chilling right now. There is this movement in us, kind of in the primary care space to say we're going to fully opt out of all of this system. Like this is broken, and we're going to go and do just direct cash pay, and that's like we're going back to the way medicine should be practiced. And as an activism, revolt against the city, against the structure. But if you think about that, that's pulling out primary care that we so desperately need. And I don't fault those doctors, but I also really feel heartbroken about all the need that I know we have, particularly within programs like Medi-Cal.
So we do have another question in the chat, and it says, even though this person agrees with your sister, and every single time that I guess she hears from you, you think that you should have the answers to her questions, right? What, if any, data gaps still exist when it comes to understanding health coverage needs or the use of healthcare for Black folks in California?
Yeah. Here's one where, I think folks have heard me say this story, which is Black women in California get our mammograms at higher rates than our white counterparts, and actually than any other group. We get the highest rates of mammograms, and yet we still die at twice the rate. That is data that has to be collected way downstream, right? That's like, did you make it to the radiation oncologist and then they actually do the right treatment plan for you? That's clinical information. And so there was a conversation about AI earlier. One of the things I think could be a silver lining in the future for us is that it's actually pulling in more data that, folks are following California's data exchange framework. We could potentially get data like that from the clinical records and pull it all together to actually have a more comprehensive view of where truly are the gaps that are driving disparities, and then how do we solution for those things. We're still a little bit guessing, right? We're like making assumptions about what we need for certain clinical disease states.
Okay. Yeah, I think we could probably talk for a very long time. I didn't get to all my questions, but I think it's important that the participants or attendees here today did get their questions heard and answered. But before we transition and wrap things up, if you want to share any last thoughts or parting words or a message to everybody, what would that be for today?
I still feel hopeful because I got to tell you, it's conversations like this. It's smart, thoughtful, right to the point questions. It's people saying, I can help. I don't have any money, but here are the things I know. Let me open up my Rolodex to you, where we have a closer relationship between other state departments, California Department of Public Health, local Department of Public Health, and community than we've ever had. Rhonda and I are like this. Like, I just think there's more connection than there's ever been. And that's where we start from. That actually could lead us to a better future.
Well, I want to thank you so much for being here today. It's always good to see you and be in your presence. And like I said, you're amazing. And I'm glad that we are connected, and I've had the pleasure to get to know you. So thank you again for being here today. And I definitely will be in touch and follow up. Okay. Okay. So just a few final things to share for today. Just a reminder that we have a big upcoming event on May 13th. Hold on here. It is our first ever virtual conference. We are hosting a mental and behavioral health conference. So it's virtual, so anybody, anywhere can attend. So registration is now open. We have an early bird discount rate available through March 31st. So register now if you are able to register now. If you see the small print at the bottom, if you register before the early bird expiration date, you enter for a drawing to win a $75 gift card. So you can go to our website, you can scan the barcode here. You go to our event page on the website, you can find all the information there. also, we want to hear back from you today and share your feedback on your experience here today. What do you think about the webinar? So if you complete the webinar survey and send it to us by Monday, you'll enter for a chance to win a Starbucks gift card. For those of you who like coffee or like Starbucks or like the food or whatever it is at Starbucks, you'll enter a chance to win a gift card to go purchase your favorite items there. So I'll give you a few seconds to scan the QR code. Charity should be dropping it in the chat. We'll also follow up when we send out the webinar recording. So there's multiple ways for you to have an opportunity to share your feedback. And then last, please stay connected and follow us on social media. It's pretty easy to remember. It's your CBHN on Instagram, you can follow us on our Facebook. We're not so much on X anymore, but if you want to be there, we're not doing too much. But everything else is at your CBHN or on LinkedIn, we're the California Black Health Network. You can also see the recordings of all of our webinars, including this one, on our YouTube channel, and that's California Black Health Network. So thank you very much for attending today and for participating. I think we may have had record attendance today for one of our webinars, so thank you for making that happen. And please stay tuned for what other things we'll be doing over the next month or so. So thank you very much and have a great day.